Hello everyone. Today we are going to study about the general principle of the fracture management. Before going to the fracture, we have to know the general principle of its like fracture and its management. So let's go with the topic. So first, fracture means there is the break in the structural continuity of the bone. So this is the fracture where you can see in the figure also there is the structural break continuity of the bone. So in this figure you can see. So fracture is divided into different types, like first, based on the etiology, like traumatic, pathologic, and the stress factor. For the traumatic, road traffic accident, fall, sport, physical, and the assaults are there. And in the pathologic fracture, like bone cyst, bone tumor, osteomyelitis are there. And in the stress, like repeated heavy loading, soldiers, athletes, and the dancer are there. So in the for the best of the communications with external environment, it is divided into open and close. For the open, it is internally open and the externally open. Okay. So uh, here you can see that open, and for the like open, then when the bone or the hematoma touches the outside environment, then it is called open. And in the close, there is like no continuation of the hematoma or the bone to the outside environment, it is closed. So for the based on the morphology, like transverse, oblique, spiral, comminuted, and the segmental, which you can also see in the figure. Here is the transverse, oblique, spiral, and then the comminuted and the segmental fracture. So for the fracture, based on the complexity of the treatment, like simple and the complex, and for the fracture, like based on the quantum force of the fracture, like high velocity injury, low velocity injury, and based on the basis of the displacement, like on displaced and the displaced. So for the simple complexity of the like transverse humerus fracture, in the complex there is comminuted fracture of the tibia, and in the high velocity injury like severe trauma, and in the low velocity injury like mild trauma, and the based on the displacement, like there will be the shift or the angulation or the rotation. So for the pathological fractures, there is underlying disease which is causing the fracture more commonly, like local disease which is inflammatory, like pyogenic osteomyelitis, tuberculosis osteomyelitis, and the neoplastic, like benign tumor, giant cell tumor, inchondroma, and malignant tumor like primary osteosarcoma, Ewing tumor, and the secondary from the lungs, prostate, kidney, and in female, breast, lungs, and genitals are most common malignant tumors. So other are like simple bone cyst, other aneurysmal bone cyst, and monostotic fibrous dysplasia can also be there. And the generalized disease like hereditary osteogenesis imperfecta, if there is the history of the repeated fracture, then we can have to suspect that if there is any osteogenesis imperfecta in the patient. And the dyschondroplasia, osteopetrosis, and the osteoporosis, malacia, rickets, scurvy, and the multiple myeloma, metastatic carcinoma, and the Paget disease, and polycystic fibrous dysplasia. So like age factor at birth, like if there is a pathological fracture, then we have to suspect that osteogenic imperfecta, and to 0 to 5 osteogenic imperfecta along with osteomyelitis, and when 5 to 20 then osteomyelitis and simple bone cyst and the primary bone malignancy, and in 20 to 50 cystic lesion are more common, and malignancy, osteomalacia, and giant cell tumor. And if after the 50 year, then osteoporosis is common, and multiple myeloma, and secondary is to in the bone. So natural process, like if there is a fracture of the bone, then there is the healing, like natural process of healing. First, there is the formation of the hematoma around the fracture, and for this it takes less than 7 days, and then the granulation tissue will come, and then there is formation of the granulation tissue which up to 2 to 3 weeks, and then there will be the formation of callus. Callus is the structure which is first seen in the radiograph in the healing process. So there is formation of the callus in the 4 to 12 weeks, and then there will be the remodeling in 1 to 2 years. Formally it is called as consolidation, but nowadays it is called as remodeling. And then for the modeling, like many years it requires. Formally remodeling is named, but nowadays there is this process is like modeling. So for the stage of hematoma, as we have talked about, it is less than 7 days. Like fracture in necrosis occur, and the sensitization of the precursor cell occur in this stage, and the stage of granulation tissue up to the 2 to 3 weeks, and then there is the proliferation and differentiation of the daughter cell into the fascia, fibroblast, osteoblast, and the fracture is still mobile. And there's the stage of callus, which is 4 to 12 weeks. So there will be the mineralization of the granular tissue callus, which is radiologically visible, and there will be the fracture clinically united, no more mobile. And then the stage of the remodeling, which is in the 1 to 2 years. Lamellar bone formation by multicellular unit bone remodeling of callus. Outline of callus become dense and sharply defined, and the stage of modeling, formerly called as the stage of remodeling, it takes many years, and the modeling of the endosteal and periosteal surface so that the fracture site become indistinguishable from the parent bone. So for the approach of the patient, when the patient come to the OPD of the emergency with the limb injury, then we have to ask for the history of the injury. Like if it is the fracture, for the fracture, like we have to for the suspect of the fracture, then the commonest sign is like if the patient come with the tenderness, and then the mobility of the disproportion mobility, like not a normal mobility. If there is, then we have to suspect that there is a fracture. Most commonly, and the patient come with the tenderness in the fracture. So if the fracture then if there is the history of the fracture, or then it is a fracture, then we have to find out that it is the closed or the open fracture. For distinguishing closed and the open fracture, if the hematoma, which is formed in the fracture of the bone, it touches the outer environment, then it is the open fracture. If there is intact skin, so it is called as closed fracture. Is the trauma sufficient to cause fracture, or like it is the pathological fracture? Is there any distal neurovascular deficit? We have to always check there any distal neurovascular deficit, because if we neglect that, then we have to compromise the limb also. So we have to always check the neurovascular deficit, and we have to use the first aid. So if it is not a fracture, then also like there is injury, so first aid must be used. And then we have to send for the x-ray examination. So most commonly x-ray is seen of the anterior, posterior, and the lateral view, most commonly, but there is unique to the different joints fracture. So if the fracture is obvious in the x-ray examination, then is it the only fracture, or is it the pathological fracture, or it is the old fracture? We have to rule out this, and we have to do the definitive cure or the treatment. For if the fracture it is not obvious, then we have to carefully trace cortices of all the bone visible, and if the fracture is seen, then again the same procedure. And if there is no fracture, then we have to treat TSB, which I'll talk here. So for the B, we have to use the first aid, and then send the x-ray examination, and there will be no bone injury. Oh, if there is any soft tissue is injured, like if there is sprains means like there is ligament tear or the ligament injury. So what degree of the ligament injury, first, second, or third degree? So for the ligament injury, if the little bit of the ligament is injury, then it is first. And if more ligament is injury, but it has not been disturbed, then the type 2, and if it is disturbed, then type 3 of the ligament injury of the sprain. So sprain and the sprain are different thing, we have to note about that. For the strain in the muscle, like partial or complete, and we have to do the treatment. And for the skin contusion, like subcutaneous hematoma, and then we have to do the drain and the rest. So in many cases also, if there is the more formation of the hematoma, uh, then it can also kink the blood vessel, and the distal part of the supply of the blood vessel may also be diminished. So we have to check any blood vessel compromised or neurovascular compromisation in the fractures. So presenting complaint and the clinical examination, like presenting complaint in the fracture are like pain, swelling, deformity, and the loss of the function. And in the examination, we have to see the swelling, deformity, tenderness, bone irregularity, abnormal mobility, and the absence of transmitted movement. So we have to main thing in the like which causes, like there is a fracture, like tenderness, abnormal mobility, and the absence of transmitted movement. Like if there is the movement in the one part of the bone, then it cannot be transmitted as it is in the normal. So we have to check these three along with swelling, deformity, and the bone irregularity. So for the common fracture at the birth is clavicle and the humerus, and in children supracondylar fracture of the humerus. This is the most common in the children. And the epiphyseal injury are also common. In adult, fracture of the shaft of the long bone are more common, and in elderly, Colles fractures and the fracture neck of the femur are more common. So mechanism are like fall on the outstretched hand, then there will be the high chance of the fracture of the clavicle and the fracture around the elbow. And if there is fall with spine force in the particular direction, then there will be the flexion injury, like and the extension injury. If the sleeping in the bathroom, like trivial trauma, little trauma, then there will be the fracture neck of the femur. And the dashboard injury. Dashboard injury means like the person is standing in the road, and then the no like if there will be the accident in the car, then the person who is sitting in the like driving the vehicle, the knee will collide with the front part of the car, and then there will be the dislocation of the posterior dislocation of the hip. So dashboard injury, in the dashboard injury, there will be the most common is posterior dislocation of the hip. And fall on the onto the hill, there will be the fracture of the calcaneum, and the hit by a stick, then there will be the high chance of fracture of the ulna. So suspect pathological fracture if the force producing the fracture is insignificant, and there is history of swelling in the around bone prior to the occurrence of the fracture, and there is history suggestive of the frequent fracture in the past, and the patient is suffering from the debilitating systemic illness known to weaken bone. So if there is a history suggesting of the frequent fracture of the in past, we have to rule out the osteogenic imperfecta. So radiological examination, at least 2 views should be requested, and the joint above and below should be included in the X-ray to not miss any fracture. As in the Montegia fracture, that this fracture is likely to be missed because the like physician failed to ask for the radiograph including the joints. So we have to, in the Montegia, like there will be the fracture of the upper 1/3 of the ulna, and that causes the dislocation of the proximal radioulnar joint. So if we fail to take the X-ray of the joint, then there is a high chance that we miss that fracture also, or dislocation. So special view shows fracture better in some cases, like X oblique view in the scaphoid fracture, and the X-ray requisition must specify the area of the suspicion in the X-ray form. So for the reading of the X-ray, which bone is affected, we have to read which part of the bone is affected, at which level is the fracture, and the pattern of the fracture, and the fracture is displaced or not, and does the underlying bone appear pathological, and is it fresh or an old fracture? We have to look for that. For the treatment, like we have to do, first thing is the emergency care, and then definitive care, and then we have to do the rehabilitation. So for the emergency care, there is the mnemonics called RICE. For R, we have to rest the patient by splinting, and I for the ice therapy, and the C for the compression to reduce the swelling, and the E for elevation to also reduce the swelling. We can use the folded newspaper or the pillow or the chest arm to rest the part of the fracture, and the ice therapy to reduce swelling, compression, and the elevation also to reduce the swelling at the fracture site. So in the emergency care department, like we have to do the basic life support and the quick evaluation of the extent of the injury, and any bleeding is recognized and stopped by the local pressure, and the examination of the fracture parts to exclude injury to the nerve and the vessels. So for the definitive care, like fundamental principle of the fracture treatment are the reduction, immobilization, and the preservation of the function. So let's go. The reduction means as the technique of setting or displaced fracture to proper alignment, like to the its original position or it's in the proper alignment. So reduction is rendered unnecessarily when the little or no displacement. Displacement does not matter initially. Example in the clavicle, and reduction unlike to succeed, like compression fracture of the vertebra. So it is like unnecessary in this case for the for reduction. So for the method of the reduction, like closed manipulation, it is the standard initial method carried under the general anesthesia, and the art of the realigning or displacement by feeling through the soft tissue. So there is the closed manipulation. So like feeling from the soft tissue, we have to align the displacement in the alignment. And the continuous traction, like it is used to counter the force which will not allow reduction to happen or will cause displacement. So it is discontinued once the fracture become sticky, and the fracture supported in the plaster cast till heal occurs. So another method is open reduction, like fracture is surgically exposed and the fragment are reduced under the vision, and the internal fixation is maintained to maintain position, like fixation is used to maintain position. It is done when other method of achieving reduction have failed. So also referred as open reduction and internal fixation, or ORIF. So for the indication of the open reduction, as like if there is the failure of the closed reduction and the displaced interarticular fracture and some displaced epiphyseal injury, type 3 and the type 4, and major avulsion fracture like fracture of the patella and the non-union, then we have to do the open reduction. For the relative, like delayed union and the malunion, multiple fracture, pathologic fracture, when closed reduction is known to be ineffective, fracture of the neck of the femur, and the fracture is vascular or the neural injuries. So for the immobilization, the reason of immobilizing a fracture are to prevent displacement or angulation, to prevent movement that might interfere with the union, and to relieve pain. So all the fracture doesn't need the immobilization. We have to remember these. So method of the immobilization, like strapping, sling, cast immobilization, where plaster of Paris and fiberglass casting tapes used, and the functional bracing can be used. Plaster cast and the use, like there are many plaster cast which you can use in the different fracture. So I think that is not of the important. So use of the plaster of Paris, there is to slab and the cast. There is like common question, what is the difference between the slab and the cast in the orthopedics department? So you have to know about that. A slab is the plaster slab covers only a part of the circumference. If it covers only the some part of the circumference, then it is slab, and the plaster covers the whole part of the circumference of the limb, then it is the cast. So there is always you have to know about the difference between the slab and the cast in the orthopedic department. So fundamental principle of the remember while applying plaster cast are as follows: immobilize the joint above and below the fracture, immobilize joint in the functional position, and the pad the limb adequately, especially in the bony prominence. So for the complication of the plaster treatment, like impairment of the circulation, plaster sores, skin abrasion, and the loose cast are the complication of the uh, this method of the immobilization, like operative method, whether the open reduction is performed, fixation should be used, and the internal fixation and the external fixation can be used. For the internal fixation, in this method, the fracture once reduced is held internally with the help of some metallic and non-metallic device like implants. So for the indication, like when a fracture is so unstable that it's difficult to maintain it in acceptable position for non-operative method, then we have to do the internal fixation as a treatment of the choice in some fracture, where in order to secure rigid immobilization and to allow early mobility, like to allow the early mobility, it can be used. And when it has been necessary to perform open reduction for any other reason such as an associative neurovascular injury, then we have to do the internal fixation. For the like type of the internal fixation, steel wire, K wire, intermediate nail screws, and the plate and the screw can be used, which you can see in the figure also. So pros and the cons of the internal fixation, like in the pros, minimal need of the external immobilization, and the early mobility of the patient, joint does not get stiff and the muscle function remain good. And the cons are like there is like uh, open fixation, so there can be chance of the infection, non-union, it requires the trained surgeon, and the availability of the implant are the cons of this internal fixation. For the external fixation, the device by which the fracture is held in the steel frame outside the limb. So for the indication, like fracture associated with the severe soft tissue damage, where the internal fixation is risky and the patient with severe multiple injury, then we have to use the external fixation, which you can see in this figure also. So for the rehabilitation, beginning at the time of the injury goes until maximum possible function has been regained, and the consist of joint mobilization, muscle re-education exercise, and the functional use of the limb. For the joint mobilization, to prevent stiffness, the joint should be mobilized as soon as possible, and done initially by passive mobilization, and once the pain reduces, by active assisted or by himself active mobilization. So for the difference between the active and the passive, if the patient does it by the own itself, then it is the active, and other person like doctor helps to movement, like doctor does the movement, then it is the passive. So motorized device which slowly moves the joint through a predetermined region of the motion can be used, which is called as the continuous passive motion machines. And the muscle re-education exercises like this can be static contraction or dynamic contraction. During immobilization, the muscle working on the joint inside the plaster can be contracted without moving the joint, which is static contraction. After removal of the immobilization, the skin is cleared, skin removed, and some oil applied. The joint are moved to regain the range of the motion, and the muscle wasted due to prolonged immobilization are exercised. The functional use of the limb, like once the fracture is on way to union, as at a suitable opportunity, the limb is put to use in a guarded way. For example, in lower limb injury, gradual weight bearing is started, partial followed by full. So walking aid such as a walker or pair of crutches, stick, etc. may be necessary. So if there is a fracture and the fracture is undisplaced, then the immobilization and the physiotherapy is there. And if the fracture is displaced, we have to do the closed reduction or the primary open reduction and the internal fixation. For the closed reduction, like manipulation, the traction can be done, and if it is come to the acceptable position, then immobilization and the physiotherapy, and doesn't come to the unacceptable position, then it is the one of the indication of the open reduction. So we have to do the open reduction and the internal fixation and physiotherapy. And if it is the displacement, like we have to do the primary like open reduction and the internal fixation, then we have to do the physiotherapy. Management of the open fracture, like the principle of the treatment is to convert an open fracture into the closed fracture by the meticulous wound care, and thereafter the treatment of open fracture is essentially followed by the closed fracture, done in three phases as like a closed fracture. Emergency care is at the site of the accident. Bleeding should be stopped by the pressure of the bandage, and the wound is washed with clean tap water or saline and completely covered with the clean cloth, and the fracture is splinted. So in the emergency department, we have to do the wound care, splinters, prophylactic antibiotics, tetanus prophylaxis, analgesics to be given parentally, and the x-ray should be done. So for the definitive care, wound care, we have to do the early wound development and the wound management. On debridement, the skin should be accessed as little as necessary, and the badly lacerated tendon are accessed. Bone end are cleaned thoroughly with normal saline, and the margin of the fracture end may be nibble or bone fragment with attached soft tissue is replaced at the fracture site. For the definitive wound management, on debridement, if there is a small puncture wound, leave as it is, and the clean lacerated wound, we have to do the primary closure. If there is a doubtful lacerated wound, observe for 2 to 3 days, and if there is no infection, delayed primary closure, and if there is infection, secondary closure should be done, and the infected wound healing by the secondary intention. For the definitive care, fracture management, and the commonly used like plaster, pins, skeletal retraction, external skeletal friction, and the internal fixation. So for the rehabilitation, it consists of joint mobilization, muscle exercise during immobilization, after removal of the immobilization, and the advice regarding mobilization of the injured limb. So for the complication of fracture like early and the late, in the early there is urgent like visceral injury, vascular injury, nerve injury, compartment syndrome, hemiarthrosis, infection, and the gas carrying, and the less urgent are like fracture, blister, plaster, and the pressure sore, heterotrophic ossification, ligament injury, tendon lesion, nerve compression, joint stiffness, compressive regional pain syndrome, or ergodystrophy. For the late complication like delayed union, non-union, malunion, avascular necrosis, growth disturbance, bed sores, muscle contracture, joint instability, and the osteoarthritis. So one thing which you should know, if there is a fracture here, and there is if the anterior and the posterior, so this is the body, okay, this is the, if there is a fracture and there is the dislocation of the distal bone, then what type of the fracture is this? Like there is the dislocation like posterior dislocation, we have to say if it is the A bone and this is the B bone, so we have to say posterior dislocation of the B, or we have to like if it is connected with the body, then we like A bone and B bone, if there is a fracture, like we have to say the posterior and the anterior, and like posterior dislocation of the B or anterior dislocation of the A. So we have to always say the posterior dislocation of the B, because A is fixed with the body, like it is the normal, we have to expect that it is in the normal position, like it is fixed with the body, which is the fracture, and then it gets to the another position, like B one goes to the another position. So we have to say the posterior dislocation of the B, not anterior dislocation of the A. Okay, so this is just a general overview. So I think this video is a little long, but after this I will make the video much shorter, just important topic only. Thank you for watching video. Thank you.